So I'm going to talk to you today about monoclonal antibodies and other therapeutics. And I'm a clinician primarily, so I spend a lot of time taking care of patients. This is the patient that we looked after not too long ago, a 76-year-old engineer. He had received 4 doses, it's really small, but he had received 4 doses of mRNA vaccine, all along the right timeline. The last one was 6 months prior to this admission. He only had a history of previous cabbage done 10 years prior, admitted with fever, cough, and dyspnea, desaturated in the emergency department at another hospital, improved with oxygen, was treated with dexamethasone, remdesivir, baricitinib, and awake proning. He improved, but he still remained hypoxic. He was sent home with home oxygen. He developed diabetes thanks to the dexamethasone. And finally, 2 months after discharge, he was weaned off his oxygen. But basically, I think this illustrates what we do as clinicians. So he got dexamethasone, he got steroids, he got antiviral, and he got an immunomodulatory agent. And so when patients are not doing well, we just throw everything at them. The one thing he didn't get was serum treatment. Now, serum treatment is something which has a really long history, going back 100 years. And this was Bering and Kitasato in 1890, who published the paper on the use of diphtheria and tetanus antiserum, which really made a huge difference. But it continues to this day. This is New England Journal 1 week ago, where they showed that it was a study of convalescent plasma in COVID-19 ARDS patients. And again, you know, when you slice and dice the data, you'll get a result. And so basically, they found if you started the convalescent plasma within 48 hours of admission to the ICU, they did a bit better. If you did a meta-analysis, though, however, there was really no difference in terms of outcomes for all the randomized trials. And in fact, it was right in the middle for convalescent plasma. So giving up on serum therapy, as many of you know, there was a lot of interest in monoclonals, and so sotrovimab was the first that actually was widely used. The initial studies published in preliminary form and later in the final analysis actually showed a benefit in patients with mild to moderate COVID-19. Now, some of you know that sotrovimab actually came from someone who we know. And what he did was he very generously donated a ton of peripheral blood mononuclear cells and plasma. And these were used to derive the antibody. I asked him, I said, did you get any royalties out of it? And he said, no, it's his contribution to science. But the story was written up and obviously it's confidential. Unfortunately, when sotrovimab was trialed in patients with more severe disease, there was no benefit in this active study. There were other monoclonals targeting mainly the RBD, and in RCTs we saw very interesting results. And this trial of in the recovery trial is very striking. It's a bit small, but what you can see is that for seronegative individuals, there was a significant benefit for casirivimab indevimab. However, if you were seropositive, you actually had the opposite result. And so this has been one of the findings which people have talked about from even before the pandemic started, and the role of immunopathology, which I think David kind of hinted at as well. And this is the group at NCID, this is where Prof. Leo works, where they showed that actually in individuals who had early seroconversion and severe disease, they had very high levels of cytokines. So there are individuals in whom the dysregulated immune system, again, which David mentioned, contributes to the pathology of the disease. But what is even more alarming is this idea of antibody-dependent enhancement, where it's not just the disease, the immune response, the cytokine, but actually the antibody contributing to that. And this has been best described, again, as many of you know, with dengue, but it is something which stymied the early development of therapeutics for the first SARS from 2003, 2004, 2005, for those of you who are involved with this. And there are multiple mechanisms which have been shown in this Japanese study where COVID could actually do the same thing. But if you're not just talking about antibody enhancement, there's also the issue of antibody evasion. And again, this is something that you would predict for a disease that is so widespread that millions and millions of people have been infected with this virus. And there are many, as again, you heard from David Smith about all the different variants. And this is from David Ho's group, where he pointed out that the rise of variants, in a way, is driven by the need for the virus to evade the immune system. So essentially what has happened is that the virus evolves, and because these therapeutic antibodies which have been developed are the most effective at blocking the virus, they are also the ones which are most likely to trigger evolution of the virus to evade either the therapy or the natural immunity which develops as a result of infection. This has been shown by, again, researchers at NCID, where they showed that, again, when you looked at plasma from the early stages of the outbreak, the original Wuhan or the wild-type strain, they collected a lot of plasma because there was a program where they were thinking of using convalescent plasma. But this actually turned out to be useful because they tested it later on against the emerging viral variants, and they found that it was very, very difficult to neutralize. And more recently, again, the same group has shown that the emerging subvariants, when you test the different monoclonals that have been targeted, that have been shown to be effective in earlier trials, they essentially don't work. The only one that seemed to have some activity was sotrovimab, interestingly enough. However, again, as David Smith earlier pointed out, essentially all the therapeutic monoclonals don't work anymore, and they are no longer recommended by the WHO in their guidelines. So because they don't work, but they don't work in the broader range of the population. Again, as a clinician, if your patient is in front of you, is requiring inotropes, is increasingly hypoxic, like I said, we just tend to throw the kitchen sink. And in the US, even though the CMS does not cover the treatment, these drugs are still available. So there's actually a mechanism. If you go to the CMS website, you'll find out how you can get access to these drugs, even though they're not covered by Medicare. Similarly in Singapore. So when we transitioned to the endemic stage of the pandemic, the previous 100% subsidy for therapeutics was taken away, but these drugs are still available, and if you feel that they're necessary, the clinician feels it necessary, we do financial counseling for the patient, and they are available as needed. In the future, again, my good friend Wang Linfa has been looking at pan-coronavirus vaccines, but he's also looking at pan-coronavirus monoclonal antibodies, and he has some things which look promising in vitro. So, many years ago, I went to a rheumatology meeting about 15 years ago, and it was really sad. It was in this dingy little hotel, and they had this coffee machine and the tea machine. 4 years ago, I went to a rheumatology meeting, and I was at the St. Regis, and they had these booths, and they had all these fancy meals. What happened in between? And the answer is the advent of therapeutic monoclonal antibodies. Okay, rheumatology used to be you decide whether to give the patient steroids or to put them in a wheelchair, But now they have so many monoclonal antibodies, and it's $1 billion market out there. So monoclonal antibodies targeting infectious agents are actually a really small minority. And in fact, if you look at the top 10 targets of monoclonals, the number one is actually the checkpoints. So the PD-1 that's used in oncology. The number one monoclonal that is sold worldwide, it's got a $19 billion market, is adalimumab or Humira, which is used in dermatology and rheumatology. And essentially, COVID is the only infectious agent on that list. So there's lots and lots of monoclonals that target different molecules, different parts of the immune system. And these were initially tried in COVID, as you all know. Baricitinib, which was shown to be promising in combination with remdesivir. When it was tried in hospitalized adults, there was some benefit. However, in the Bari-Solid-X trial, which was in more severe or critically ill patients, there were equal numbers of mortalities in the placebo and the baricitinib group. So again, it may work in some individuals, but it's not consistently beneficial. Tocilizumab, another monoclonal, very widely used. So baricitinib is anti-JAK. Tocilizumab is anti-IL-6. And again, there was some benefit in the recovery trial. But interestingly enough, it was in the patients who did not receive steroids. In the patients who did receive steroids, there was not a very significant benefit. And when they went to hospitalized patients, Again, this trial, I forget what the name was. All of these trials have fancy names. This one, there was really no benefit, tocilizumab versus placebo in the 28-day mortality in hospitalized patients. So people moved on to repurposed drugs. And again, David didn't really talk very much about Paxlovid, but you all know that Paxlovid came from a cat drug, Nirmatrelvir, ritonavir. And I was trying to look for the original studies on Paxlovid. And actually, there's a study, and this is again a bit too small, but it's a randomized trial in cats on feline infectious peritonitis. And apparently, there's no data protection laws for cats because they actually list the names of all the cats. They've got names like Snuffy, Peanut, and each cat's name is there together with their viral load before and after treatment with Paxlovid. So again, ivermectin came out. It's now not recommended except in the context of a clinical trial. And I'm going to tell you a story about what we did with the repurposed drugs way back in the early days of the pandemic in the first year. So Singapore started out without a lockdown. But unfortunately, in April of 2020, we had to have what was known as a circuit breaker. And before this, actually, some colleagues from Hong Kong, including my good friend Julian Tang, actually did this modeling study. And what we showed, and again, what you all know, is that when you have a lockdown, you keep people at home, right? So you prevent transmission between households. But what you do is you increase transmission within households. So because if you're at home, all you're going to do is you're going to be seeing your parents, your whatever it is, whoever's living at home. So you spread the virus. If you've got it, you spread it to your family members, but you don't spread it to anyone else. Now, that's not a big deal for a household of 3.2 people, which is the Singapore household size, except in the migrant worker dormitories. And so this is what we saw. It was written in March 2020 that if you have a household size of about 40 people in one room or 20 people in one room, you're likely to get explosive outbreaks. And unfortunately, that's what happened. So we did have explosive outbreaks in the migrant worker dormitories. And again, they tried to preserve the healthcare system by locking down the dormitories, keeping people within the dormitories, treating them if they were sick. And there were huge attack rates. They went up 70, 80% of people in the dormitories were infected. Interestingly enough, there was still a handful of people who never got infected despite that. And that's another object of interest. And this is not a novel strategy. This is a strategy that was done in Japan. You know that with the Diamond Princess, where they took individuals off the ship if they were unwell, but they kept them on the ship so that the virus wouldn't spread to Tokyo and Yokohama, the city itself. But unfortunately, the workers themselves, even though we sent medical teams down to look after them, they felt that they were like sitting ducks waiting to get infected. So my neurologist colleague said, can we do something about that? And so we came out with an open label, randomized control trial, 40 clusters, and we gave them alternatives. And again, bear in mind, this was in May 2020. Oral hydroxychloroquine, ivermectin, a povidone iodine spray, oral zinc, or oral vitamin C, which was the active control. The primary outcome was lab evidence of confirmed SARS-CoV-2 infection. Unfortunately, just as we were about to start the study, this fake study came out in the Lancet, suggesting that hydroxychloroquine was associated with increased mortality. It got retracted. The UK hydroxychloroquine study got cancelled. Authorities called us up and said, are you going to go ahead and do the study? And we said, yes, we'd like to do that to just see whether it works or doesn't. And they made us go through we had to do an ECG for every single person that we were going to give hydroxychloroquine to. We had to make sure they understood it, get a translation into their own languages. We had a video. We had a person there speaking to them about it. And we monitored them every day. We checked their heart rate, we monitored for symptoms, and the results actually surprised us. So in the end, we managed to recruit and randomize 3,400 men. Again, these are huge migrant worker dormitories. We randomized them to the arms. The hydroxychloroquine arm was the smallest arm because we had to exclude anybody who had even a premature ventricular complex. And to our intense surprise, there were actually two groups which had benefit. One was the povidone iodine throat spray group, and the other was the hydroxychloroquine group. Very small number of individuals dropped out. So we sent it to the New England Journal, rejected without review. Lancet, rejected without review. We sent it to JAMA. They sent us a nice review. We answered all their questions. and they still rejected it. So we asked them why. And the editor was very honest. He said, I understand, and we struggled over this decision, but we don't know if any of these are better or worse than placebo. We are very worried about publishing something that says that hydroxychloroquine is good. And remember, this is 2020, okay? A certain person was still the US president. So we actually offered to delay our submission. But unfortunately, as you heard, we got caught up in the politics of the thing. And finally, it got published in the International Journal of Infectious Disease. Nick White wrote an editorial, which gave us a little bit of credibility. It got into the Straits Times in Singapore, and it was posted by our colleagues at Singapore General on Facebook, and it got taken down by Facebook. So Facebook contacted me later on for something else, and I said, you guys taken down a peer-reviewed publication, and they apologized for that. And I'm not a believer in chloroquine, okay, believe me. This is an earlier study done on chloroquine for influenza. And it's still, something I wish somebody would reproduce our study, but unfortunately nobody can. It didn't work for influenza. So to wrap up, I'm going to tell you another story about a patient. So this is a 76-year-old retired manager. He happens to be married to one of our nurses. He had a history of nasopharyngeal carcinoma 10 years ago, squamous cell carcinoma of the lung. He was hospitalized in August 2023 with dysphagia and dysarthria from a late complication of radiotherapy. He was admitted with fever, cough, and dyspnea, initially treated with Augmentin. Chest x-ray didn't look too bad. He had a lobectomy, that's why his right lung is a bit smaller. And he deteriorated. He was admitted to the ICU, and his flu AB PCR came back positive for influenza A. He was treated with oseltamivir. He initially improved, but he has persistent respiratory failure. We repeated his flu PCR 10 days after admission. It was still positive for influenza A, H3N2, as you would expect. And as you can see, he's in a lot of trouble. So we got a bronchoalveolar lavage and a biopsy, and it was suggestive of post-influenza bronchiolitis. So now he has to be treated with a combination of steroids, and we've given up on the oseltamivir at least. So this is the dysregulated immune response, which again David was talking about earlier on. And there's been a lot of interest in monoclonals, but there's only one monoclonal. Actually, now there's two, sorry. That's why this slide, just to remind me. There's two prophylactic antibodies which have been approved. And the first is obviously pembrolizumab for prevention of RSV. And the second is nirsevimab, which is not available in Singapore. But again, it's used primarily in premature infants who are at risk of severe RSV disease. And both of them do work. The advantage of this is you don't have to give it on a regular basis. It's got a longer half-life. When I was asked to give this talk on monoclonals, I said, I haven't done anything at all on monoclonals, but I got to go and read up about it. What we did do is we did a phase 1 study on a polyclonal. And this was for H5N1. And this was with an organization called Fabintech, which unfortunately I think they ran out of funding. I'm not sure who has picked up on this, but it's using the FAB fragment, and what they did was we did this in healthy volunteers, and we saw very good levels of antibodies to H5N1. But this platform they had preclinical evidence that it works in H7 and H3 as well. So those are monoclonals targeted against specific targets. Now, steroids, again, are the oldest of these kind of immunomodulating agents, and we all know the results of the recovery trial, which showed a significant benefit, but primarily in those who required oxygen therapy. For those who did not require oxygen therapy, there was actually no benefit. And the striking thing is when this was further analyzed in those admitted to hospital and not requiring ventilatory support, there was actually harm that resulted from steroid therapy. And this is similar to what David mentioned about influenza. Once you find individuals who do not have this fierce immune dysregulation, then you end up creating harm because they get side effects from the steroids. They get GI bleeds, they get hypertension, they get all kinds of other problems. So this is my last slide. So basically, I think the answer has got to be, personalized medicine, which is the buzzword for all these cancer and metabolic disease. But I think it really does apply to infectious diseases because In some patients, the virus overwhelms them and you need to give them antivirals. In other patients, it's the immune dysregulation which is going to kill them. And this is actually one of our registrars who analyzed a large cohort of patients that we had. And what he said was there is this so-called, he's not the first one, I think it was a group, can't remember where it was, who pointed out there is an inflammatory phenotype. And so he compared age as a risk factor, age, the CT value of the swab as a surrogate for the viral load, presence of comorbidities, and hyperinflammatory state. So age, slight impact, but not statistically significant. CT value, not significant. Presence of comorbidities definitely was significant as a risk factor for adverse outcomes. But the hyperinflammatory state had an adjusted odds ratio of 5.8. So in other words, if you were in the hyperinflammatory state with a higher CRP or IL-6, we didn't measure IL-6 a lot, but mainly CRP, you had 5 to 6 times the odds of a bad outcome. So I think that what we need to do is basically be a good doctor when you're looking after a patient and try and determine which is the patient who actually needs the antiviral, which is the patient who needs the immunomodulatory agent. And you know, when you do an RCT, you have to get 30,000 patients or whatever it is, you're going to end up mixing them up. And so that's why you get all these rather strange results. So is there a role for monoclonals and therapeutic agents in respiratory infections? I would say maybe. Probably yes. But I think they got to be used appropriately. Thank you.
Thank you for the energy you bring to the very final discussion. And we want to learn the names of the cats. And did your cats get included in the trial?
Yeah, you can get the slides, I think.
A question which I think you might have answered from online. What's the mechanism that allows the steroids to work? I think you sort of answered that towards the end, but
yes.
Why do steroids work?
Yeah, I mean, steroids have been in place since the 1940s. And we know that they're broadly immunomodulatory, but they have multiple targets. And this whole, I did my infectious disease training in the 1990s when we were trying to treat sepsis with various cytokine blockers, and every single one of them failed. Because we realized that steroids had side effects. Steroids are so multifactorial. They affect your blood pressure, they cause GI bleeds and all this kind of thing. So we're trying to narrow the targets down, but they've all seemed to fail. And I think right now, as far as I know, we don't know what's the exact mechanism by which steroids work in this sense.